let's make sure we're not confusing. There's three large models of how to organize healthcare finance. The one is the big, complicated mess of everything that we have here. But the two more sort of standard poles, one would be the United Kingdom's approach, which is called a National Health Service. And that's socialized medicine. That's like the VA. That's where the government literally employs the physicians and the hospitals. And that's socialized medicine, because socialism, as you know, is the government owning the means of production. That's how they do it in the VA. That's how they do it in the United Kingdom. And that is not what my group is talking about. Instead, that's one model, is a National Health Service. We're just talking about national health insurance, just the insurance part. And that's how the United Kingdom, that's how Canada works. That's how Medicare works. And you brought up the issue of innovation a few moments ago when we started, and I didn't touch on that. But you brought up telemedicine. If you think about it, during this pandemic, who was the first of the payers to start reimbursing for telemedicine in an organized major way? It was traditional Medicare.
Yeah.
Traditional Medicare, has a small administrative functionality, and they, as a small leadership group, were able to say, hey, we got to do telemedicine. They quickly, in weeks, recognized the need to do this, and in weeks implemented it. And then over the next several months, most of the other payers came around and said, yeah, that was a good innovation. Thank you, Medicare.
Yes.
So
yes.
Medicare can really roll out an innovation quickly.
I wish they would have rolled it out years ago too. I mean, because to me, Ed, that was one of the silver linings of COVID, was because the three of us, Randy, Rick, and I, have all been in the wound care space for years. And, Rick was talking about, let's say in a rural setting, it's great. But, it also works beautifully in inner cities where, for our patient populations who have physical limitations to get to the clinic all the time. Mm-hmm. And even the cost of transportation, if somebody, let's say, has to come from a facility even into a private office or an outpatient wound center, it's extremely expensive. So this has been certainly, to your point, I think it's great. It's been a really good thing. And I'm glad you clarified it too. What you're talking about here is in the way you broke down the systems, because that's the key point. Having this national insurance is the key, I believe. We've all had our frustrations in dealing with insurance companies having to play Mother May I just to do the right thing for your patients. That's why one of the things that has led me to finally say, 26 years of this, and I think it was time to look to do other ways to, provide my experience and help more people on a grander scale. But the frustrations were daily. The time wasted was never ending. The goalposts are constantly moved. And the persons ultimately who are making the decisions are not qualified.
I think, oh, sorry.
Yeah, my last little point on this too, I would always remind my patients too. So listen, your insurance company is not there to provide health insurance. They are not there. They don't care about your health. They are there to make a profit for their shareholders. Mm-hmm. That's what an insurance company is created to do. They just happen to be, they're the conduit in a sense.
I wanted to, before I forget it with my white hair, the point that Ed made there about the insurance is a great one, because the point to the average guy out there, at least anybody over 50, is what you said. Their fear is the National Health Service and socialized medicine, as we called it. And any of us, at least my experience, and I'm sure yours, and you hear it on the news all the time, the VA system was awful. And my interaction with the VA system was still awful. And
it still is. I'm dealing with it now with my dad. It still is.
They may throw money at it, but they don't deal with it. So that's the fear down the road of that system. But when Ed puts it out there and says, we're talking about the insurance, we're not talking about delivery of care. We're talking about how you do that. And I think that's where you go with that. And that's because the lobbies for the insurance companies are going to be amazing, and the major healthcare systems. We all go back to the major healthcare systems that seem to work and when we talk about the group setting, we're Mayo and Cleveland Clinic and Oxford Clinic, and there are others, but those where they've worked with these efficiencies for years. And so maybe that's a good model. I don't know about the payer side of it, but the physician side of it.
Well, folks, I want to I want to shake the box a little bit here, if I may. It seems to me every time we talk about how we're going to fix the system, we spend a great deal of time talking about who's going to pay, who's going to be responsible for the bill. Now, my problem is this: in the United States, according to some information that I've gotten from a few different think tanks, but the United States spends a good 50% more of its gross domestic product on healthcare than the next lower developed country. I'm not talking about comparing it to Cuba. So for me, my question is, where is the money going? Does it have to cost this much? And that has to be coupled with the discussion about who's going to pay, about the discussion about insurance, which I think we're going to have. The complexity of modern medicine is such that it is going to be expensive. There's no question about that at all. But if we're spending double what they're spending in France and Sweden and other countries that live a very similar lifestyle to ours, where is the money going? So
it's not physician salaries. That's not where the money is going, being squandered. That's not.
This is the song that we want to sing.
Right, this is true. That's not.
You bet.
There's all of the models that look at this essentially project a consistent physician earning. That's not where the problem is. The problem is in two other huge areas. The first is administrative waste, and that's not subtle. So if you go to any hospital, you'll find, the number of beds, and then you'll find a legion of people in the billing and insurance related work. So I believe the number for Duke University, is that they have, I think it's around 800 or 900 hospital beds across their system and 1,600 billing and insurance functions. On average, the average hospital has roughly one billing and insurance person for every hospital bed. That's an army of well-intentioned, hardworking people. But compare that. So we have a legion of people doing that, and physician offices do as well. Compare that to Canada, where Toronto General is a comparable size to Duke, has about, I forget the numbers, about 800 beds, and they have, I believe the number is 12 billing and insurance people for their roughly 800 beds.
That's
so
incredible.
It's just because we've created this complexity where the hospitals need to, count every drip on the IV pulse so that they can maximize their reimbursement. And there's all this complexity that's fabricated. And so roughly a third, that's just one example, the hospital piece, but roughly a third of what we spend on healthcare in the United States is going to the administrative functionality of the insurance. And understand too, that's just the hospital side and the insurance side, but they have offloaded, the insurance companies have offloaded a lot of that administrative expense to us in practice. So the typical physician has something on the order of $100,000 of staff to manage the insurance functions of their practice. And in Canada, the same person would have about $20,000 of staff. So that's cost, that's administrative cost that we bear that gets built into the fee schedule that then looks like it's part of us, but it's actually the insurance industry hiding their administrative functionality on us. And just to make that part of it worse before we get to the second part of pricing, but the other part of this is that the average physician, this is hard data to get, but in Missouri, I have the data that the average physician in practice has about $200,000 in accounts receivable. It's not charity work, it's accounts receivable. That's stuff that you did, that you bill typically a third-party payer for, and that you're waiting on average almost 12 months for. So in other words, and that doesn't exist in Canada. So in other words, the average physician in the United States is giving about a $200,000 free loan, interest-free loan for a year to the insurance companies. Why in the world would we want to do that?
Can't get that deal at the car dealership.
So the first piece is the administrative waste. That's roughly a third, and it should be more like 10%, but it's about a third. Then the second piece, of course, is pricing, where the same exact drug in the same exact package produced by the same exact manufacturer is sold for roughly 50% off elsewhere in the world. We spend roughly double. And you think, well, you know, so if we cut our prices down to the world prices, then they're going to stop producing it. Well, no, they're not selling those drugs at a loss overseas, right? They're not selling it at a loss. They would simply stop selling it if that were the case. We know that they can sell it at those prices and still make a profit. So, you know, the prices here, so it's the two pieces. It's the administrative waste and it's the prices.
Right.